Hello, my name is James Lasky, and I would like to introduce a very special guest and friend, Dr. David Armstrong. Welcome to another episode in our three-part series on pressure injuries presented by Rehabtronics. This episode is going to be focused on emerging technologies for the prevention of pressure injuries. So again, we're focused on prevention in this topic, not treatment or assessment. And so the objectives are for this session is what brings pressure injuries in the spotlight today. And we want to examine, and I'm going to ask Dr. Armstrong some questions specifically about some of the new and emerging technologies in pressure injury prevention in this space. Dr. Armstrong, could you just reiterate, we've kind of hinted at a few of these technologies in the last couple of episodes, but can you reiterate over the last few years, what is new about the pathophysiology of these deep tissue injuries? Because with that new information, that's, I think, really driving some of the technical developments in pressure injury prevention.
Yeah, sure. So I'm happy to. What's exciting is we've already covered some of these things, but I think some of the identifications of the fact that there are really micro kind of ischemic sort of conditions at play, as well as issues with the viscoelastic quality of tissue that can be measured, as well as identifying kind of both stick and slip and being able to model that has led to the fact that maybe we can measure what we're managing and then ultimately get out in front of some of these pressure injuries, which is enormously exciting. I think. I think one that's kind of shown promise for a very long period of time has been subepidermal moisture and so-called SEM. There are now data to support that over a prolonged period of time. I think even meta-analyses that are now being developed. So that's one. So imagine identifying the viscoelastic quality of tissue by identifying whether it was at risk to break down or not by its subepidermal moisture. That then could lead someone to pay extra attention to a given area to maybe modulate that area. And then imagine adding on top of that something that could intervene. Something that could intervene, maybe something medical, like topical, that might improve quality of the tissue, or maybe it could be something surgical, maybe it could be something micro and mechanical, like we were talking about, with maybe a patch, if you will, that could provide intermittent electrical stimulation to give little micro contractions of the localized musculature to improve the quality of tissue, to improve blood flow, and thereby reduce risk for pressure injury and tissue loss. So all of that's super exciting. Then you add on to that other kinds of imaging systems, thermography, and other types of imaging tools that we can use here that are hyperspectral, which is basically beyond our vision, that could really assist. I think this is very exciting. Also, many of the things we've been working on at our Center to Stream Healthcare in Place include really cool epidermal electronics that could sense things on the skin, all the things that we mentioned, but then other things that could be placed on the patient that are very, very inexpensive, that can give all kinds of really cool information on a position of a patient, whether that person is in an ICU, on a normal ward, or for us, the most interesting thing is when they're at home, and giving us that information in an identical kind of dashboard, just as if we were, they were down the hall. So imagine you were able to handle your own sort of dashboard for this patient population, and if and that dashboard was being assisted maybe by a series of clinicians and even a call center of interested clinicians. That, I believe, is what we're going to be seeing. That's next, and next isn't very far away. Super exciting.
So just coming back to just a couple of things that you mentioned. So these SEM scanners, there's a variety out there. They've been around for a little while.
Yep.
can you share a little bit about what you're aware of in terms of, I mean, no one tool is the answer. Of course, each company wants to say that, their device will cure, we'll never see it again. And we know that in all our spaces in terms of healthcare, it's multifaceted. Not one thing is going to cure everything. Truly, if everyone quits smoking, we'll still have jobs. We'll still have people with COPD. We'll still have people with diabetes. We'll have people with peripheral vascular disease and issues of limb loss. So it's, it makes a difference, but it's not the one thing. So with the SEM scanners, can you share what your sort of experience or your knowledge is about in terms of the pros and cons of just it as a device on its own and how well it's working for early detection?
Well, I think the data seem to suggest, which would be our experience, which is that it does seem to identify people that are at risk. Also, things that can identify people at risk, include other kinds of imaging systems like, I think we mentioned it in previous discussions, like ultrasound.
Right.
And that's something that's readily available as well. You can be using different types of, echo and episcan and other types of tools that are showing that could show, issues at areas of osseous prominences, which is also very, very exciting. So I think you have those. You want to see the tissue.
I mean, the goal of this is also to see tissue deep, because with pressure injuries, where, as we all know who are listening to this, I'm sure everyone's aware that what you see on the surface is not what's going on deep. And I'm sure you too have had experiences where the skin doesn't look so bad, and then you touch it and it's just boggy, and you're going oh my gosh, that is abscess, or if it's not an abscess yet, that tissue is a terrible risk if it's not already necrotic, even though the skin is intact. So it's great.
That's exactly right. And theoretically, if you could even identify, if you had a sophisticated enough ultrasound device, increases in SEM and subepidermal moisture content. I don't want to get too out in the weeds and things.
Sure.
But you could do that along with the various SEM, subepidermal moisture measurement sensors that exist now. I already mentioned thermography and tools like that, and hyperspectral, like different kinds of spectroscopy. These are very, very interesting technologies for which there's likely going to be even more data to support their use.
And what you're talking about is great in terms of detection and risk mitigation, but it doesn't help us. These tools so far don't really help us once we identified someone who's at risk or who has tissue at risk or has an injury. It just tells us that it's there. It doesn't really help us, that piece, in terms of the actual preventing it from getting further or preventing it in the first place. It just tells us about it there. So I wanted to move on to, in terms of up and coming new emerging technologies with Prelivia, which you've described already, using the technology that has been known for a while in terms of an electrical stimulation electrode put at the sites of risk, wherever those sites are risk. And these other tools are great for identifying, is it an ischial tuberosity? Is it the sacrum? Is it the hip? Where is the issue? Is it the back of the head, the shoulder, whatever? And providing some intermittent mild electrical stimulation to enhance and facilitate tissue oxygenation. And I mentioned in the one of the other sessions that the data so far shows that it can increase tissue oxygenation by about 28%, and it can decrease suppressor injury damage by 80%. And so again, it's in its trials, it's new. They're looking at workflow in terms of, if it's typically in the critical care, it's going to be nursing who's applying it. So it has to fit into their workflow, which is very,
isn't that key? And you've really summarized it beautifully. But if it can fit there, and it can assist, and it's an extra set of hands rather than just another tool that's going bing, and distracting, then I think it holds real promise.
Right. So can you share a little bit, because the Prolivia device, it's intermittent, mild electrical stimulation. This is not treatment. That there is a difference, and you see this in the diabetic population as well, that we also use e-stim as a treatment modality versus this is using it as a modality to prevent the injury in the first place. So can you share a little bit about what that difference is in terms of how electrical stimulation may be used?
Yeah, well, again, we're talking about using the use of very focused electrical stim in these pads at specifically for reduction of the risk of developing a pressure injury. In this case, there are quite a lot of data suggesting that electrical stimulation may be beneficial in wound healing over a long period of time. There are a lot of studies that have suggested that, varying levels of quality. But this is something different entirely, because you're getting out in front of the problem and you're really not causing a change in wound healing. What you're doing here is you're causing just little micro fibrillations and contractions of the micromuscular, the small muscles around an area and around a bony prominence that may improve the blood flow, thereby reducing the risk of developing a wound in that area, and also probably pumping out a lot of that highly inflammatory moisture that transudate, as it were. Because sitting there, you can detect it with increased SEM. That is an inflammatory soup. That's like a witch's brew of inflammatory cytokines and chemokines that is doing nothing but bad or evil to your tissue from the inside out. And pumping that out locally is likely one of the mechanisms here that we're probably seeing.
So we're really looking at a device or a tool that is being used 24/7. It's being continuously used at a low intensity, whereas the more traditional electrical stimulation for wound healing, we're messing around with the anode and cathode, and we're using a higher intensity stimulation over 20 minutes, and we're really focused on either looking at its antibacterial effect or its epithelialization effect. Which
this is very different.
Very, very different. And then in terms of your expectation, we'll kind of finish this up now, is in terms of the types of patients that you might see in critical care that might use this type of, it seems to me it could be pretty much used on anybody. But are there anybody at risk, or just like we might pick people at risk and put them in a special bed? It seems like we could use these other tools to look at people that were at risk, and using our clinical judgment to identify people at risk and say, okay, we've got the bed, we've got our turning, and we have this other tool that, to add to our toolkit to help prevent pressure injuries from developing, or grade 1 and 2 pressure injuries from getting worse. And I think that's a really key thing, is a person might have one, but we don't have to throw up our hands and give up. We can actually try and mitigate it. It's not treatment, but it's trying to get it from being worse. So do you see some patient populations that maybe this might not be useful to or appropriate to? I kind of have a list in my head, but I was curious what ones you come up with.
I mean, I guess just, folks for whom I think the obvious one that I would be thinking about is someone where there's an end of life issue where we're doing just comfort care right now. That may not be, while it may be helpful in some of those patients, I don't think that would be the first place that we would.
That's a really good point. That's a really good
something
point.
Like this, but that still, again, there still may be a role, but it would be likely different, muted, if you will.
Right. I guess I'm thinking of certainly like an open wound. We wouldn't put, it's already there. Probably state, grades 3 and 4 pressure injuries, and they've got other issues. There may be some issues related to, because you're applying electrical stim for somebody who has maybe a cardiac demand pacemaker, could be an issue possibly, or if there's an unstable fracture in the area, like, if you have a fractured pelvis, do you really want to be stimulating? I mean, again, we could discuss that. And I know often it's me talking with the intensivist saying, okay, here it's not a contraindication, but it's a concern, and let's talk about it and use our clinical judgment.
I would call that more of a relative contraindication, but that could be something that you could discuss, I think, with the either the intensivist or the orthopedist or whomever.
So I'm thinking for you who's in the trenches, both, and I know you've got, now you're still treating patients. I know you're administrative and you're faculty teaching. I mean, you have so many different roles, but this has to be really an exciting time for you as a physician in healthcare, even as crazy as things are, and the demands of the whole healthcare system are so challenging. But to see all these amazing developments in terms of in this case, we're thinking about prevention, but in terms of assessment and treatment for pressure injuries must be pretty exciting for you and your colleagues.
Oh yeah, this is such an exciting time to be a doc in general, a foot doctor specifically, way out the end of this anatomic peninsula, My dad used to say the best gift you can give anyone besides your love is perspective. Out at the end of the body, it kind of forces you to have this little different perspective, and it forces you to team up with the anatomic mainland, as it were, and gives you and that perspective is that there's a big challenge, but it's an exciting time to really make a difference.
Good. Well, thank you so much, Dr. Armstrong, for your time. And on behalf of Rehabtronics, I want to thank you for doing this. And like I said, the times that we've got to meet and chat, we could talk for hours, I'm sure. And I'm sure I'm not the only one, but I really enjoy your perspective and your knowledge and your generosity of time and sharing your perspective. So thank you for participating, and take care.
James Lasky, you had me at hello. Thanks a million.
Thank you. You're too kind. Okay. Thanks, David.
Take care.